Dr. Ken Landau. Thanks for watching. Let's talk about bipolar disorder. Bipolar disorder, up until recently, was referred to as manic depression. It's one of the major causes of disability among young people. Now, we all have moods that fluctuate from somewhat up to somewhat down, depending on the pleasant events in our lives or the amount of stress that we undergo. But with bipolar disorder, we're talking about severe and persistent mood swings. And these mood swings result in psychological distress and behavioral impairment. They range from very high to very low. Now, it's in the spectrum of conditions that we call affective disorders. One of those is just unipolar depression. So unipolar depression looks like the depressive part of bipolar disorder. Bipolar disorder is the mania or hypomania and the depression. But in unipolar depression, it's one pole. So you just have the depression. So you go from depressed to relatively normal to depressed to relatively normal, and there is no attack of either hypomania or mania. But in bipolar disorder type 1 and type 2, then we have mania and hypomania mixed with depression. But interestingly, about 3 times as many people have the condition as are able to be diagnosed with current criteria, because the current criteria are pretty arbitrary. A bunch of people sitting around in the room deciding what kind of symptoms are necessary to make the diagnosis. Well, they establish the number of symptoms, and oftentimes a person doesn't have quite the number in order to make the diagnosis. Those are subsyndromal cases, and they're more common than people who make the diagnosis. Well, it's important that we make the diagnosis early and we get on treatment at a relatively early stage in order to prevent some of the long-term complications of the condition. But in spite of that, we know that the average delay from the time symptoms begin until the diagnosis is established, oftentimes about 10 years. Well, when the symptoms begin, sometimes they're nonspecific, sometimes mood lability, sometimes it's just depression, so people are misdiagnosed as suffering from unipolar depression because they haven't had any manic attacks as yet. Bipolar disorder is a distinct entity. It was described originally in the 1850s by Jean-Pierre Fauré, who's a French psychiatrist. If we look at bipolar disorder, it's separate from the psychotic disorders, it's separate from the mood disorders, and we talk about bipolar disease type 1. Bipolar disorder type 1 is associated with attacks of depression interspersed with attacks of mania, and some of the people with bipolar 1 have hypomania. Bipolar 2, they have the hypomania and then they have the depression, and sometimes they're normal too. People can have an atypical bipolar-like phenomena. Those are the subsyndromal cases or cyclothymia. Well, the major thing that separates unipolar depression from bipolar depression is unipolar, one pole that's just depression. Bipolar is 2 poles, depression and the mania or the hypomania. And then people can be normal for some period of time in between the episodes. So if we talk about bipolar disorder type 1, those have overt attacks of mania with a range of manifestations. So you have to have at least one manic attack in order to make the diagnosis of bipolar disorder, BPD type 1. You have to have overconfidence or grandiosity or talkativeness or extreme disinhibition or irritability, and some people have a decreased need for sleep and highly elevated mood. And sometimes people can develop some psychotic episodes. And these would be either delusions or hallucinations. They can actually occur in up to 75% of the manic attacks. But people who have bipolar disorder type 1, they can also have the hypomania, although 5% have just the mania. They don't even have the depression. And we know that it's important to make the diagnosis because the episodes of any severity can compromise the psychosocial function, and oftentimes with the mania requires hospitalization. People who have bipolar disorder type 1, those people have much more severe prognosis. They have a more tortuous evolution of their condition than people who have bipolar disorder type 2. symptoms tend to be worse. Now you can see that here's a graphic of bipolar disorder type 1, where you have above the line the manic attacks, below the line the depressive attacks. And you can see that the depressive attacks can be relatively minor. You can have mild depression, or you can have more severe depression. On the other hand, on the other side of the vertical line, you can see in bipolar disorder type 2, manic attacks are above the line, remember, but these aren't really severe. These are what we call hypomanic attacks. But the depression can be about the same. Another graphic that illustrates that sometimes the people have relatively long periods of normality, and then they can have a hypomanic attack, and then subsequently they can have a depressive attack. Then they can get to be back to relatively normal. Then they can have a manic attack. And then they can have even a mixed attack, and that's the oval area, where people have both symptoms of mania and depression right at the same time. So it's very important to realize that the symptoms a person has when the person sees the doctor are not necessarily indicative of the entire array of symptoms. And as a matter of fact, most often people have relatively few symptoms when they do see the doctor. But it's important to realize that if we look at this condition, we find that it's different than bipolar disorder type 2. In bipolar disorder type 2, we have the hypomania, not the mania. So in order to make the diagnosis, we need at least one attack of the hypomania sometime during the lifetime. Now, if you've never had an attack of hypomania, then you don't have bipolar disorder type 2. Has to have at least one attack of the hypomania, and additionally have to have one attack of significant depression. Now it seems that there's more rapid fluctuation in people who have bipolar disorder type 2 than type 1, but we have a high rate still of psychiatric comorbidity, and we have to worry about the recurrent suicidal behavior that's associated with impaired quality of life in both people who have especially bipolar 1, but also in bipolar 2. So during periods of the heightened mood, some people can be affected with depressive symptoms. In order to make the diagnosis of a manic attack, you have to have symptoms for at least 1 week. For depression, you have to have symptoms for at least 2 weeks. Now, the time limits, again, are arbitrary. There is no biologic basis for the timing of these attacks. If we're talking about cyclothymic disease, that's recurring depression with the hypomania that lasts for in excess of 2 years. But remember, the people don't meet the threshold for major affective disorder. And as a result, they just seem to fluctuate between hypomania and mild to moderate depression, but never have the full-blown episodes. Now, most people who have mania also have episodes of depression. And depression is much more common, it's much more long-lasting, and it's much more distressing than the mania. And it's during these attacks when people have an increased risk of suicide. The increased risk of suicide, about 6 to 7% in people with bipolar disorder, as opposed to the general population. It's about 20 times more, 30 times more than it is in the general population. And even if we don't talk about suicide, it seems that people who have bipolar disorder have a death rate that's at least 2 times as great as the general population, oftentimes related to cigarette smoking or to other kind of physical disorders. Then we have a couple variants, and one of the variants is switching. We have relatively rapid or frequent cycles from depression to mania, simply referred to as rapid cycling disorder. That's 4 discrete episodes over the period of the past 12 months. And then sometimes, like I showed you on that oval, we have periods of mania that overlap with depression. Now, originally it was thought to be just in bipolar 1. Now it's thought to be in bipolar 1 and bipolar 2. You have to have at least 3 symptoms of each pole in order to make the diagnosis. So at least 3 symptoms of the mania or hypomania, at least 3 symptoms of the depression. Now, this condition, both the mixed episode and the rapid cycling, they tend to have worse prognosis. They tend to have an increased incidence of comorbidity and an increased incidence of suicide. The incidence of the condition, somewhere between about 1.5% if we look at the population just in the past year, about 2.5%, up to about 4% if we use a broader definition. The rate seems to vary by country, sometimes due to cultural differences. Bipolar disorder type 1 is a little more common than bipolar disorder type 2. Bipolar disorder type 1 associated with maybe a rate of 0.6% of the population, bipolar 2, 0.4%. But like I said, subthreshold bipolar disorder, probably about 2 to 3 times as common. So that's what we call the subthreshold disorder, where people have either cyclothymia or the atypical episodes. And these people, about 1.4% of the population, that's how we get to around 2.5% of the population total. Well, if we look at bipolar disorder type 1, incidence in men and women about equal. On the other hand, bipolar disease type 2 seems that women outnumber men. The average age of onset tends to be relatively young, somewhere between age 12 and age 30, average about age 20. The earlier the onset, the worse the prognosis. Interestingly, the earlier the symptoms appear, the longer time it is to make the diagnosis. These people have more severe depressive episodes. They have more anxiety, more substance abuse. And certainly, since the conditions affect young adults, you can see that this is a population that's economically quite active. So it costs a lot to the individual and to society. Now, if we look at people in general practice, so people who are just seeing their family doctors, the incidence, just according to screening tests, could be almost up to 10% of the population. And it seems that about 15% of the people who are receiving treatment receive the diagnosis of unipolar depression, which is very frequently called just depression or major depressive disorder. Well, those individuals, about 15% of them, actually have bipolar disorder. So the first attack is usually depression. That's why it's frequently misdiagnosed as major depressive disorder or just depression. But most of the people who have bipolar 1 or bipolar 2, they have depressive episodes that last considerably longer than the manic attacks or the hypomanic attacks, and that occurs throughout the entire course of the illness. Now, unfortunately, there can be overdiagnosis of bipolar disorder, especially if doctors just rely on some of the questionnaires, because questionnaires tend to have a lot of what we call false positive diagnoses. So that's why it's not sufficient to make the diagnosis just on a checklist. You need to have evaluation by a skilled professional. Now, in addition, just as with all psychiatric conditions, because of our lack of really total understanding of them, it seems that we have a lot of comorbid diseases, other diseases that are present along with the bipolar disorder. So anxiety in about 70%, substance use in about 50-60%, personality disorders in maybe as many as 30%, 35%, attention deficit hyperactivity disorder. And any of these conditions going to increase the burden of the illness, worsen the prognosis. And the fact that there are so many other conditions, well, like I say, that probably has to do with the way we define the condition and our lack of knowledge of what the true abnormality is. Now, other kind of comorbid conditions, some people have the metabolic syndrome or migraine headaches or obesity. Obesity is very important if you have bipolar disorder because it changes the levels of lithium in the system and it changes the reaction that you have to some of the antipsychotic medicines like Seroquel because you tend to gain a lot of weight with the medicine. Tends to go along with cardiovascular disease and cigarette smoking and fibromyalgia and subthreshold hypothyroidism. In other words, your thyroid is low, but it's not really low enough to make the diagnosis of hypothyroidism, sometimes associated with diabetes. And interestingly, it seems that as we change the season, going from winter to spring or going from summer to fall, that also tends to precipitate attacks. people who take steroid drugs, especially prednisone, that kind of steroid, androgens, the male hormone, people who take INH, isoniazid for tuberculosis or get electroconvulsive therapy, ECT, people who don't sleep enough, people who have altercations with a loved one, people who are on antidepressant medicines. Because remember, antidepressant medicines bring you back up to relatively normal, supposedly, but sometimes they overshoot and they can cause an attack of mania. Pregnancy can cause the problem, other hormonal conditions associated with it, alcohol, drug use associated with it. Well, if we're going to make the diagnosis, we have to consider a variety of other diagnoses and rule them out in order to make the diagnosis of bipolar disorder. But unfortunately, some of these conditions are really difficult to distinguish. So for instance, depression. Again, the American Psychiatric Association has a cockamamie list of symptoms that you have to have. Well, if you don't have enough symptoms, then you can't make the diagnosis of depression. Schizophrenia, substance misuse, personality disorders, especially the borderline personality disorder, attention deficit disorder, fatigue from anemia or congestive heart failure, hypothyroidism, anxiety, alcohol, substance abuse, eating disorders. Well, the diagnosis seems to be made more often in people who are complaining of the depression than the mania or the hypomania. So you need a directed interview with the person, and you need some of the relatives, because the person might not recognize some of the symptoms that they've been having. And it's interesting that only about 20% of the bipolar disorder patients are having symptoms, having depression, at the time when they have the diagnosis. Now, it would be very helpful if we had a biomarker, some kind of a blood test, some kind of an x-ray test. We don't have any of that. We just have a lifelong episodic illness of varying severity and a varying course. Sometimes the onset of mania doesn't occur until after a person has had one or more attacks of the depression. So if a person has an attack of mania, it lasts on average about 2 to 4 months. By definition, it has to last at least 1 week. With hypomania, some people say it can be as short as 2 days. Most people say it has to last at least 4 days. When you have the mania, you have increased mood, increased motor drive. It's finite in time. It's going to end at some point in time. You have differences in severity, some very severe, some moderately severe, some mildly severe. But they do interfere with the person's ability to function in society, function at work. And sometimes, as I mentioned, it might be associated with some of those psychotic reactions or delusions. People with mania have high or irritable mood. They're very active. But unfortunately, the activity is scattered and unproductive. They sleep far less than normal. They dream up all these grand plans that they never could carry out. They have delusions of grandeur or grandiosity, megalomania. People are involved in sexual activities that they later regret. Sometimes they have problems with the law. Well, they have high levels of energy. Sometimes they have paranoid ideas or they're suspicious. They have puffed up self-esteem. They have rapid or pressured speech. Sometimes they have rapid thoughts. They're easily distracted. They behave in a more reckless fashion than normal. Well, sometimes those people with the mania, as I mentioned before, may have the delusions or hallucinations. Now, hypomania, much less severe than mania, it's not as severe an impairment. They don't need hospitalization. Might not even impair their occupational function. Actually, these individuals might seem to have increased productivity and a better mood than normal. Sometimes they view the mood as positive, view it as desirable because they can get more work done. Bipolar disorder type 2, at least the hypomania, well, it's often under-recognized. But unfortunately, if you have hypomania, the hypomania may be all you're going to have, may be a forerunner of a depressive episode, or may be a forerunner of a true manic episode. So you do have to pay attention to hypomania, even though it doesn't seem to be nearly as severe as either the depression or the mania. Patients, they tend to struggle with depression, but the families, they tend to struggle more with the hypomania or the mania. Now, how reliable the Diagnostic and Statistical Manual is to make the diagnosis, that's controversial. We do have some screening instruments. There are a variety of screening instruments: mood disorder questionnaire, the bipolar disorder screening scale, a series of these. But if they're positive, you need additional evaluation. You need additional evaluation by a human in order to see if the symptoms that you're writing down on the checklist actually are sufficient to make the diagnosis. They're not very sensitive, these tests, so that it's estimated that about 25% of people who do indeed have bipolar disorder, well, they're going to test negative. So if we look at long-term follow-up of bipolar disorder type 1, we find that 13 years later, still about half of the people are going to have significant number of their weeks, half of the weeks, are going to be affected by their illness. About 30% going to be affected by the depression, about 10% of the weeks going to be affected by the mania or the hypomania. If we look at bipolar disorder type 2, still 13 years later, about 54% of their weeks are affected by their illness, which means that about half of the time they seem to be able to function relatively normally. Depression occurs in about 50% of the weeks, hypomania only about 1% of the weeks. So that's the story about the mania and the hypomania of bipolar disorder. It's a condition that affects up to about 2.5% of the general population, frequently diagnosed in people between ages 12 and 30 or thereabout, average age about 20 at diagnosis. But at least at the present time, it seems that there's often a 10-year lag between the onset of symptoms and making the diagnosis. Now in part 2, we're going to talk about depression and we're going to talk about treatment. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.